Good afternoon to all of you. Welcome to this lecture today, the Fullbright chair lecture by Professor Vijay Mittal on role of simulation for physicians in 21st century. So Dr. Vijay Mittal was born in Lahore, and he did his MBBS from Amritsar and then his post-graduation from PGI Chandigarh. In fact, just now I heard from him that he actually got selected even at AIIMS as an undergraduate way back in 1962. But he came and he saw this daunting big building and he said he'll be better off in a small town like Amritsar, so he joined there. So subsequently he moved to US, and there he did residency in surgery and then fellowship in vascular and transplant, and all along in his career he has been a general vascular and transplant surgeon. And he has special interest in pancreatic transplant and islet cell transplant. More than that, he has been into medical education in a very big way right from inception, and is one of the first to take up simulation as a method of training not only undergraduates and even residents. And he is the program director for surgery and also in charge of medical education at Wayne State University, not only for surgery but for all the medical specialties. So I invite Dr. Vijay Mittal to deliver his talk.
Thanks, Dr. Seenu. And it's really a pleasure to come back to AIIMS, I think, after 7 years. I was here, I think, in 2014 when Dr. Mishra was here. And that was also under my Fullbright program when I visit multiple institutions, multiple cities and countries. So this is an ongoing process for me to kind of share what we have now, where we are going, what are the few variables which we can adopt, whether we can modify or you can adopt something. So looking at it, if you look at what the medical education model is, used to be Halstadian model. You get a preceptorship model, do one, see one, and then teach one. That is completely obsolete now. Now I think the new model of the present is see one, practice many, and then practice too many more by doing it, and then you teach one. And that is, I think, the simulation training will be. Why we do this simulation? I think the public will ask us sooner or later in India too. Is the doctor who is taking care of me is competent enough to touch me? And that's where the simulation part is going to play the role. Our main aim is to produce competent physicians, nurses, and the other healthcare workers. If you look at it, we in 1999 report where all this actually started, the seed was born, put it in 99. Why simulation? And I think Dr. Gaba from Stanford put it very rightly. Is a technique, not a technology. Some people are taking it like a technology and it's being kind of formulated. Is to replace or amplify real experiences with guided experience that evoke the replicate substantial aspect of the real world in a fully interactive manner. So he defined it nicely at that time. And if you look at the history of simulation, it's not a concept. It's not new to medicine. It has been practiced in ancient time when we were just examining patients and patients were taken as simulators. The first medical simulators were simple models of human patients varying from different cultures and continents. The introduction of the human patient simulation towards the end of 20th century was a major step in the modern simulation. And the credit goes to our friends in anesthesia. That was the earliest simulation or simulators which were brought to the medical field. In 1920s, first to develop the simulation technology and incorporate simulation into the medical education by John Lumley from Mayo. Then in 1950s, we started the process of creating ladder-lay model. Then 60s, 70s, and 80s, we started getting SimMan 1, SimMan 2, SimMan 3, and then the MIST trainer came in 1997. So history was there, but we never adopted completely these things. If you look at it, other professions, simulation was adopted way, way earlier. And if you look at simulation training is well established in military, the aviation, which I'll talk a little more in detail, nuclear power, NASA plant, and gaming industry. The flight simulation is the first one which is used extremely in the aviation industry to train pilots and other flight crew to both civil and military aircrafts. It's also used to train and maintain the engineers for the aircraft system. The military use of simulation for training soldiers, military medical professionals to teach and maintain the skills. Now, if you look at it here, the first aircraft simulator was created by Wright brothers in 1903, long time ago. Then in the French simulator, which was the second simulator in civil aviation aircraft, was made in 1907. And if you look at it, the present simulator, where every pilot, every crew person, every engineer has to undergo every 6 months to recertify in the type of the aircraft they flew, because the aircraft changes. 737 cannot be flown by 747 pilot. Same thing is in our medicine now. We need to adopt those philosophy. Simulation in aviation history is long. It is well established. We need to adopt. Flight simulation improved pilot skills. Certification required on simulators prior to flying. Recertification on a simulator is required 6 monthly now. And there's an intensive simulation required to pilot different aircrafts. And I think if you look at the message is very clear for medicine, we need to adapt that model. And this is why we need to do it. Aviation model is, you might have heard the word SOAP. Before you sit in a flight, there's a standard operating procedure. There are about 20 pages. They have to fill it up. Everything is all right. Everything is checked. Tick mark. And the checklist and protocols are done. Then followed by the flight is finished. Like we are doing in the operating room. If we have finished a procedure, is there a debriefing? Open lines of communication between the teams. This is important. Everywhere we are a procedural room in medicine, there's a team who is working with that. And we need to follow the principle of civil aviation, prepare the teams. And there's a definite escalation following the flight. There's a report they have to fill up what was right, what was wrong, and what can be modified. The team training, and which will be also introduced in medicine now and healthcare workers at every level, will be the empowered junior members to vote concern. The old days are gone when I think the juniors could not open their mouth. We need to speak up. If you don't think something is right going, then appreciate it. If something is not going right, make yourself loudly audible. Train seniors members to listen to the concerns and questions rather than just viewing them as a subordinates. That's another thing we in medicine needs to educate our people. So the renaissance of simulation in United States came in 1999. And if you might have heard in the news, To Err is Human, there was a book written by Atul from Boston. And then there was a news in the New York Times that due to medical errors and mistakes, 88,000 people died. The reason was because loss of communication, not well trained, fatigued physicians, fatigued nurses. So everything was blamed on this thing. And then it was that we need to have some sort of training before things are done properly. And that was the wind of change in states. Intense focus on quality and safety of healthcare workers. We pay attention, which was our organizational structure. They made it compulsory. We need to do it. Then there was a call for educational reform across the continuum of professional development. That was another joint commission which takes care of our hospitals and the medical schools, the LCME, which takes care of the medical schools. Then the recommendation from Institute of Medicine, which is a very big body comparable to NIH in states, they said use simulation to ensure that clinical training is safe for the patient. And if you, what I mentioned a minute ago, 99, it was a one case, Libby Jones case you might have heard in the news, where a young girl was unintentionally not given treatment properly. She died. It was a political issue. And at that time in states, if 80-hour per week rules were introduced for medical training. And that still persists. Develop simulation for the use of skills assessment. You have to be assessed. When you're skilled, you need to say you really did or not. Use simulation technology to improve individual and team performance through interdisciplinary team training. Use simulation for problem solving, recovery of those problems from the simulation, and then crisis management. So I think it's important for us to understand that we have to go through this process. Then why teach this simulation? Why do we make all these big buildings and big instrumentation? It's inexpensive and cost effective for sure. The cost of a patient life versus what we spend here is incomparable. One patient death is too much. Enhance learning objectives, accommodate different skills level. Everybody will need a different. Medical students versus residents versus fellows, they have different levels. Safety engages scenarios. And this one we are teaching nowadays in the operating room, lot of them. Virtual learning, that is the most important thing. When you are doing something on your trainer, it can be paused, you can replay it, you can review it, and then you can have immediate feedback and correct it till you get competent in that item. Then there is another wind of change came in, and that was a little hard to swallow for everybody. New accreditation model and standards were established for medical students by LCME, for postgraduate education by the ACGME, and then for the nurses. So everybody jumped in. We need this curriculum. You need to have it. And that was the next step. It was made requirement for maintenance of certification and maintenance of licensing. You see, in US, every physician is licensed every 4 years. Every physician is certified every 2 years. Now it's coming to 1 year. Before it used to be 10 years. So these are the requirements. We have to fill up 50 hours of CME every year to their boards, specialty boards. So this was another hard thing to swallow, but we swallowed it. And then I think it was pursuit of innovation, simulation-based education training. At that time, American College of Surgeons came in to be a helpful guide to all the physician, nurses, and medical students, and they established the accredited educational institution, which was made a necessity for every institution who has a training program to have a simulation center in states. If you look at it, Confucius in 450 BC, educational theory report, the adult learners are active learners. It's not one time we finished med school and you are a doctor, no more. You will be doctor lifelong. So you need to be educated lifelong. Tell me and I'll forget. That was Confucius' statement. Show me, I might understand and remember. Involve me and I will understand at that time. So same thing is a progressive process in simulation. If you look at it, retention power of human being. If I just do a lecture without showing you slides, you'll absorb or retain 5%. If I do audio visual by slides, you might retain 20% or so. If I demonstrate, which is the animation, 30%. If I do simulation or webinars, it increases to 75%. And if I involve and teach others, it will be up to 90%. So look at the retention rate, the processes. And I think simulation takes the higher level of retention rate. I'm going to go through now some of the specialties and what are the simulators available at this time. In states, primary care is considered as internal medicine, family practice, pediatrics, and OBGYN. These whole 4 groups are our primary care physicians. And then we have medical subspecialties, and I'll look at some of these surgical specialties also. Now, what can we train in simulation? There are technical skills and non-technical skills. In the technical skills, we can take how much time you take to do a particular skill. Did you make mistakes? Were you able to correct them? And then number of attempts you did to complete that task. So those are the technical skills we can kind of teach everybody. Now the non-technical skills are very hard to teach. Non-technical are teamwork. Are we working as a team? And that's where the team training has to be incorporated into simulation centers. Are we communicating to each other or to our patients well? What are our techniques? Everybody has a different technique of seeing patient in the office. But we need to teach which is safe for the patient. Don't be judgmental in medicine. I know I might have been judgmental at times, but we need to learn not to be judgmental and then start developing the leaders in simulation. And we have just started a program, Teach the Teachers program, which is we are not sure whether we have teachers who can teach simulation. So under the simulation department of ACS, now we run 3 programs, Teach the Trainer, or the trainers are well qualified to teach. Now, if you look at the primary care, there are 13 procedures which we expect every primary care physician must be trained and qualified. Surgical specialties all come separately because they have mostly procedure-related simulations. OSCE, I think everybody does it, but we have a objective structural clinical simulation. If you look at it, this picture here, I'll show you. It's a versatile multi-purpose tool that can be utilized to assess healthcare professionals in a clinical setting. They can be evaluated the areas most critical to the performance of healthcare workers, such as communication skills, ability to handle unpredictable patient behavior. And this is how it looks like. We have a 20-room facility for OSCE. These medical students and residents, they will be entering, there will be a patient, which is a model usually, sitting in. And then we have a central TV stations where one faculty member is watching all these 20 people. How the physician is behaving. How is he sitting? How is he interacting with the patient? And I think that will give us feedback from the patient as well as from the assessor sitting there. Central line placement, I think you have enough. I think I saw here. You have enough material available. Basics of fluid management in critical setting. Placement of ultrasound guided central venous catheters. It is essential now for patient management, whether it's subclavian route or the IJ route. Simulation will decrease incidence of line-associated infection because we also teach in that skill how to dress up after putting the central line. So I think we need to be careful. These are the various modules with ultrasound available in the market. And I think here you might have little different, but arterial line placement, same thing. It's important in the ICU or in the operating room, wherever you're doing procedures. Simulation is done for ultrasound guided or palpatory method. We teach both of them. But now I think ultrasound is so easily available in states. We have now the latest pocket ultrasound, which physicians just carry in their pocket. So I think it's becoming more and more available, and it can be done. These are the various models available in the market. So it can be taught very easily. Intubation, this is, I think, the airway management. Every physician in every specialty must know how to intubate a patient in case of emergency. Being a physician, it's our moral responsibility to learn this thing, how to intubate. We don't have to call anesthesia or respiratory therapist to intubate a patient. It's a basic skill, a must for airway protection for every physician. These are the various available in pediatrics as well as in adults. And I saw your unit here. It's beautiful. You should be proud and privileged to have that. Thoracentesis. You don't have to call a surgeon, being a physician, to do a thoracentesis. So we need to teach. critical care scale for large effusions. It can be done under ultrasound. Usually, we always, and I have seen at ILBS for the last couple of weeks, there's a pleural effusion called IR. That's not the philosophy of a physician should be. We need to do ourselves. We need to own a patient and do it. These are the various kits and tools available. You can do under ultrasound. You can do by tapping. So there's a lot of methods. So skills needs to be taught to every physician. Suture and knot tying. This is another basic principle skills we need to teach every physician. And even nurses we need to teach. Sometimes you are in a place, there may not be a trained surgeon. So a physician should be able to have essential skill for all physicians in all settings. Simple, interrupted, continuous, vertical matters, horizontal. There are 5 kinds of stitches. You can learn at least one of them. Simulators range from simple foam kit to virtual simulators with sensors. How you are moving the movement of your hand or instrument. They are available. So these are all the various available, which is a basic suturing kit. This is for the episiotomy we have. And this is a virtual sensor simulator for stitching. Gives you a feedback with report how was your movement, how was your stitching, where you made the error or the angulation was right or wrong. And this is the knot tying module available. Basic ultrasounds, this is another thing. We should not be dependent upon always a radiologist. Physician as such should know basic ultrasound physiology for outpatient clinic as well as in the pediatric ward. In trauma bay always it's used by our residents, medical students as a fast examination for trauma. Drainage of breast abscesses in your office you can do. And these are the various kind of ultrasounds available now which are portable. There's some laptop. Symbionics has come up with a very small compact ultrasound machine which is this one. And the virtual reality simulator, it's a little bigger one, but they are much in the miniature size available now. This is for the nursing and for our medical students. Nasogastric tube and Foley catheter insertion. And I think everyone should know how to do it. Don't be dependent upon other healthcare workers to do it. Chest tube placement. It's not expected of everyone, but physicians should know it. And I'll give you a very good example of it. One time we are in a flight and one of my friend, patient was there. He was a internist. Patient had a pneumothorax. He was able to just take a knife and put it in finger, and then the air hostess give her a tube, the oxygen tube. That's all it was done. So we need to learn the method at least. So I think it's important for us to do. These are the various, whether you can do simple, straightforward, ultrasound guided, and the tension pneumothorax, you should be able to look at it clinically and put the tube. Look at the simulation for pediatrics. New approaches for medical education to enhance resident and attending training. In pediatrics, even the attendings are supposed to go every year. Some certification regarding procedures about the airway management. Resuscitation training programs, which is our advanced pediatric life support, APLS, and neonatal resuscitation program, which is the NRMP. Every pediatric NICU physician has to be recertified every year. So this is a requirement now. And these are the various simulators available. Pediatric resuscitation drills, which we do almost every few months. Then we have a lumbar puncture for pediatrics. And then we have a Sim Junior. Sim Junior is a pediatric resuscitation module. Obstetrics and gynecology, that's another one. If you happen to see a US graduate of OBGYN diploma, there are squares on one side, and every year they have to put a sticker on that to practice in OBGYN. Because they are supposed to do simulators mimic critical events have shown to reduce mortality, birth canal, dystocia model, and the C-section model. They have to take a sticker and put it in. For the maternal fetal medicine, you have to get a sticker and put it on. So I think it's becoming, the public should see that visibility of those stickers, that my physician is competent and qualified and certified. These are the various OBGYN simulators available. C-section, hysterectomy simulator. This is our recently modified virtual simulator with lot of operations on it. We have a virtual reality simulator for certain procedures, and then for every procedure we have a module. Simulation in cardiology. So I'm just going to touch few of the medical subspecialties. Understanding and refining system to improve patient outcomes. ST segment elevation MI simulation, very important because we have an obligation door to balloon timing. If any patient is more than 30 minutes in door to balloon, that case is investigated by our American Society of Cardiology and Chest Physicians. So we need to look at the proficiency of the system, whether we have trained them well to do the best. Simulators for running codes and cardiac lung ultrasonography. Cath lab simulators. That's another one I think very important for our cardiology friends. And these are the various simulators available at this time. You'll have the code call VR simulator, Angio Suite. This is just a module laying down. You have approach to the groin or to the radial artery. You can watch where your catheter is going. You can deliver a stent, and it's a full procedure you need to learn. Then we have the TE simulator for the cardiology now available, and the code call drill. Let's look at for pulmonology. There's a rising role of simulation in primary care residency and pulmonary fellowships. Positive training outcome with simulation, lot of literature. Vascular access, bronchoscopy, intubation, and EBUS simulators. So those are also available now. Simulation program established by American College of Chest Physicians. They have put up a curriculum now, which is required for pulmonary fellowship, which is a 3-year fellowship after the internal medicine. And here are the various simulators available. This is our bronchoscopy simulator. This is a EUBS, which is an endobronchial ultrasound simulator, and the VR intubation drills. Everything needs to be taught, especially to the pulmonary fellows and pulmonary subspecialists. Gastroenterology. This is another big branch, which is a procedure-oriented subspecialty, used by 42% of the program at present, becoming the fundamental means of practicing endoscopy. The American College of Gastroenterology now have made it mandatory that during their fellowship, they must do 85 colonoscopy, 50 upper endoscopy, and 15 ERCP. So for that, this is what is available for them. Cochrane colonoscopic method, this is a very primitive module, but this is the one now we use in our centers. It can do an endoscopic mentor. This is virtual, automatic, with modules inserted into it, which are the 18 modules on this thing. You can do colon, gastroscopy, ERCP, EBUS on this thing, EUS, and then we can do all the procedure related to the biopsies, control of bleeding. So those modules are available. Let's go through the surgical specialties quickly. So that's, I'm not going to touch too much time on these things. Fundamentals of ultrasound sonography that is required for every surgical graduate. Despite the development of ultrasound courses by ACS 2 decades ago, many residents still lack formal ultrasound training, and that's why our ACGME, which is our accredited council for graduate medical education, made it compulsory now that any surgical resident who graduates must have a FUS certificate, which is fundamentals of ultrasound sonography. That's required now. And this is all the basic ultrasound training, which is a computed simulators, FAST, which is the trauma bay, which is 10 cases are required by surgical resident, central line placement, and for the breast examination. So these are all the component of the FUS certification. FUSE, that's another one. It's not required yet, but this will be down the road. In the operating room we use so many kinds of surgical energy. So now we have made fundamentals use of surgical energy. I think this will be made specially compulsory for the attending surgeons, because we use so many things of surgical energy, and look at it. Now we have created 11 modules on this thing. And it's in the process now that when a surgeon working in the operating room must be related to all these apparatuses in the operating room. These are cautery. We take it for granted. Use a cautery. What happens if something doesn't work? We don't know. We have ligature now, harmonic scalpel, ABZ, Cuzzard, and radiofrequency ablation. These all equipment we need to understand before use it. We should not be dependent upon technicians and nurses. We should also be knowledgeable about these things. So this is coming up now. And if you look at it, down the road, FUSE will be a requirement for majority of the surgical field. Minimal invasive surgery, which is essential to the practice of surgery now, is the laparoscopic, which is the FLS, and let me go through that. It has a cognitive part, which is a multiple choice question. First you have to pass that, and then you have a technical part, 5 technical skills that give you the certification of FLS, which is required for surgical graduation. And this gives you the 5 steps in the FLS, which is a peg transfer, which is a pattern cut, circular cut. Then you have a ligating loops use. Then the intracorporeal, extracorporeal suturing. 5 steps you have to do to get certification. There's a minimum time you can take to do it, and you cannot take more than 2 attempts. So this certification is also required for surgical graduation. These are the various lab mentors which are available now. And this is what we now use at our centers. These are the basic five tasks, followed by the modules which are available. Each module costs us about $18,000. So this is the money worth spent, I think. Then we have the FES, Fundamentals of Endoscopic Surgery. This is also required for the surgical graduation. It also has cognitive skills, which is a web-based multimedia presentation of didactic content, followed by technical skills, which is a virtual reality platform. And this is FES was designed for medical and surgical residents, fellows, practicing general surgeon, gastroenterologist, and other physician to learn the basic endoscopic skills required to form a foundation in the practice of flexible endoscopy. FES is meant to set a validated benchmark of understanding and skills in the basic endoscopy. So this is now required, and this has 13 modules. You have to go online, and then you have to do the exam on the GI mentor, which has 5 steps, again the same as laparoscopy, but it has additional retroflexion of the scopes. When you do gastroscopy, you have to retroflex the scope. Same thing you have to do in the colonoscope. So that is a basic skills we have to talk. Now the vascular subspecialty is becoming bigger and bigger in states. So is here, I guess. And we have created now Fundamentals of Vascular Surgery. It's a module online, which has a lot of modules. We train them. There is no curriculum set up yet. It's in the beginning now. Soon we'll have a requirement of FES for the vascular subspecialist finishing the training program. It has 29 modules. I think we are going to put it online. There'll be a review process. There'll be assessment strategies of all the vascular steps, whether it's stitching, patching, or you are having bleeding, infection, those will be there. The endovascular model will be a physical model. There will be a virtual model. But at this time, we have the patch model end-to-end side vascular anastomosis. Everybody does it, I think, in the simulation lab. But this is the actual endovascular simulator which we have now to teach our fellows how to put the U-bar. Actually, endovascular reconstruction, they need to learn on simulator first before they touch a patient. Orthopedic surgery. There's a lot of procedures they do. We just need to know whether they are competent enough before they put a joint. So orthopedics training is more efficient with simulators. They have adopted a little bit faster. Multiple training simulators for open surgeries are available. I think you have cadaveric material available to you here. Multiple surveys and prospective studies have shown improved intraoperative performance of the residents. And simulators at present are available for spinal exposure, fusions, K-wire and Steinman pin technique, laminectomy, discectomy, and osteotomy. And I think there are some of them here shown. This is a OSIMTech and OrthoVR simulator. So everything market is you demand something, the commercial people will make something for you. So I think availability is there now. Otolaryngology, highly technical and demanding specialty. Very hard to convince them to adopt to these things. Despite lack of evidence in outcomes and limited high validity simulators, rising need of simulators. Still we need some fine tuning to the simulators in ENT. At this time, we don't have much. Voxelman is available for the head portion. VR simulator for ENT has been created, but it has not had been validated yet fully. Ophthalmology, German and Egyptian people, they are more apt to this thing. They have developed quite a bit. There's a steep learning curve for direct fundoscopy, indirect ophthalmoscope, cataract simulator available now at the present. And if you look at it, eye examination from Japan, eyelash direct from Germany, then we have another eye cell cataract for Germany, and the eye exam simulator from Japan. So this is in the process. You will see more and more coming up. Thoracic surgery, we have multiple surgical boot camps for our thoracic fellows. Practice of port placement, lobectomies, robotic pneumonectomies simulator are available. Limited literature shows improvement in clinical outcome and fellows, yet it has to be adopted fully by thoracic specialty. There are some available. If you look at it, plating, lobectomy, putting the trocars, and this is a bench anastomosis bronchial as well as the parenchymal repair. Neurosurgery, they have accepted quite a bit now. Significant interest to explore and utilize simulator and virtual reality. Multiple aneurysm and spine courses available with up-to-date simulators. We have created a 10-station microsurgical training center now, which is only for plastic and neurosurgery people. So neurotouch simulators have changed the way we look at the neurosurgical simulation. If you look at it, the various things are available now and much more to come in neurosurgery. Now the last thing I want to touch is the team training we just introduced about 2 years ago, which is the team step training. We have created a curriculum for team training now, which is a team strategies and tool to enhance performance and patient safety. Team step stands for that. The communication failure is the leading source of adverse events in healthcare, and you'll be surprised to note that 88% of the deaths in medicine happens due to either no communication, miscommunication between the team members, or the information was given wrong. It's a third-hand information. So we need to be very careful, and we need to put attention to the team step training. Team step is a team-wise based teamwork system for improving patient safety within any organization. So we'll have multidisciplinary boards now, multidisciplinary teams. But what is the function of each team member? We need to educate them. For improving communication and teamwork skills among healthcare professionals, a source of ready-to-use material and training curriculum to integrate teamwork principles in all areas of healthcare system. Scientifically rooted in the more than 20 years of research and lessons from the application of teamwork principle in civil aviation, which I showed in the beginning. Now, Team STEP was developed by our Department of Defense, DoD, and the Agency for Healthcare Research and Quality. So Team STEP was done by a lot bigger group than the simulation group. So Team STEP is important, and hopefully we need to pay attention to that. Now, why do we do this team performance? Team performance is to streamline the knowledge about a process, get the attitudes down to one level of each member, and then improve the skills to the same level. Why we do all these three things is for the patient's safety. So I think three things we are looking all over the world now. Are we providing safe, quality, and cost-effective care to our patients? This is another important thing. Whenever we do something, always ask ourselves in debriefing. We have debriefing room in our centers, which I think you have smaller rooms here too, which is 10 people sitting, all the team members. And they ask each other without any hesitation what they did, when they did it, how they did it, why they did it, and how they can improve. That is the question we need to answer on debriefing, and that's how we are going to improve. If you look at it, the whole base of simulation development in the world is patient safety and quality care. Now we are assessing these, all the skills we are teaching. There's a lot of theories and methods. The one most commonly used is the Miller pyramid competency hierarchy, how you go from bottom to the top, and then you can start teaching others. This is all the other healthcare workers has been engulfed now into this whole process. Medical students, there were no exam before. So now they have introduced this USMLE Step 2 OSCE type exam since 2004. So every person, whether you go from here or our own graduates, American kids, they have to do USMLE 2, where there's a center only in Philadelphia. You have to go there, you have to take those exams, 12 patients I think, and scenario you have to pass it to get license in states. Residents, as I mentioned, for surgical graduates it's becoming a tough. They have to get FLS, they have to get the ultrasound, they have to get the FES, and now lately, next year we're going to add the fundamentals of robotic surgery, which will be a requirement. It's just like food and drug administration, you must have a FDA. Any appliance or any thing in medical technology we develop, it has to be approved by the FDA. And FDA goes through a process. American College of Surgeons and the SSIH, which is the Society of Simulation in Healthcare. There are some other subspecialty organizations. Credit to these organizations. I always say kudos to them. ASA, which is the American Society of Anesthesiologists, they were the first one in 1920 established some sort of simulators in their specialty. ACOG, which is American College of Obstetrics and Gynecology, which they do their own now, which is requirement for their recertification, and the same which is for the emergency medicine now. So in addition to those two main organizations, there is some subspecialty organization. Now the ACS, they have two levels of accreditation. One is focused, which is the basic, and then there's a comprehensive, which is the higher level, where you can be the examination center for all these exams. At this moment, this is last year figures, we have about 100 programs which has been accredited by American College of Surgeons and 75 by the SSIH. So about close to 200 programs worldwide has been accredited to give them a source, resources by these two organizations. This is the center we opened in 2005, which is called now Simulation and Education Center, which I directed for a long time now. And we have this 18,000 square feet, two centers, one different 2 miles away, one in the main building. And then we have 8,000 square feet of Neurosurgery and Orthopedics Simulation Center, which is shown here. These are our journal platform which you have here, and I think with the help of few people we are going to modify this tables myself. I think I took a picture of yours. So there are still gaps in simulation. There are problems identified and we are trying to implement them. So I think limited availability of trainers. We need to educate the faculty. Whether our faculty is trained to educate our trainee. So that is a very big thing for us. Inadequately trained faculty, that's everywhere. All 5 fingers are not the same. And we need to get that to an equal level. Focus on simulation rather than the curriculum. And I kind of blame a little bit myself too in developing the surgical curriculum by American College of Surgeons, which is extensive. I think it's a little overboard we have gone. So hopefully we'll be trimming it down a little bit. One size fits all specialties not. So we need to have every specialty's curriculum different. And then inadequate training pathways to ensure acquisition of proficiency during the introduction of new techniques, technology, and practicing physicians. My final note, simulation has great potential to improve patient safety. I know and I believe in that. And I think early evidence suggests that this method of education leads to increased patient safety. Last year, we have now started a fellowship in simulation under the umbrella of American College of Surgeons, which is 1-year fellowship. It can be done in only 12 centers in states. It's not yet fully adopted or incorporated in all the centers, but it's available. Now the last surprise I'm going to give you this. This will be the next wind of change in the healthcare, which will be cybersecurity and artificial intelligence, which is going to come actually next year. We have a meeting in Washington, which we are going to talk about it and why we are thinking about this. Artificial intelligence is to study algorithms. Algorithms will be developed down the road for everything we do in medicine based on the data collection which will be kept in cybersecurity. The machine learning algorithm that will improve automatically through the analysis and experience of individual physician. So this artificial intelligence is going to play a role in the medicine pretty soon in the next 5 to 10 years. And potential applications will be notify attendings if trainees are nearing critical portion of the case or require additional assistance to complete the case. We have started a pilot project under SAGES now, only for 2 procedures, lap chole and sleeve gastrectomy. This is laparoscopic procedures. We have put chips in the instruments. If you go in and make a mistake, there will be a red signal on the screen. 1, 2, 3 times. If you do 3 times, after that you cannot do, your instrument will stop. Then your attending has to come and save you. So that will be the role AI is going to play down the road. We don't want you to make a mistake on a patient, to harm a patient. Telementoring is going to happen. We have now telemedicine in critical care. We have telemedicine in radiology, which is available, I think. We see almost 50% of the reports in US, which are done by the Indian radiologist sitting here. It's rampant. Peer review will be done. Augment and the Mortality and Morbidity Conference with simulation-specific video review. If you do a procedure, it will be videotaped. It will be reviewed by your committee set up in the department, then there'll be a feedback. So those things will come up. So I think there is a new road which we have to adopt. And next year we have a meeting now, the surgical AI regulation policies and oversight. And we are going to have a lot of game players on the table, which will involve the surgeons, the government officials, the hospitals, because they have a stake in this, payers, the insurance companies will be sitting around it, malpractice insurance companies will be sitting, and then the industry and the patient representative. So we have these groups will be on the table to look at it, how the AI will be incorporated into medicine down the road. Now, actually, before I came to India, we had two companies which are kind of giving us guidelines how to integrate into your system. It's very costly at this time. For our 2 units, which I kind of manage overall for the medical education, the cost is $1.2 million every year just to have the AI integrated into our system. So I have picked up only for radiology at the time being, because radiology will give us a lot of safety. Sometimes 20% of the radiology reports will have addendum added after the initial report. So that's a problem we are facing. So we might get our AI component into radiology first and then see the further. So I think a lot to learn, see what, practice many, do many, and then teach one when you are competent to teach. So I think the road is away further, much more to learn, much more to do. Thank you very much. Any questions, I'll be able to answer.
Thank you, Dr. Mittal, for giving us an insight as to where simulation is advancing in the US. So if anybody has any questions, you can ask. Better is, I think we can discuss it in the pantry, because the convergence block is to be closed for maintenance. Actually, they said 11:30, so I got it postponed to 2 o'clock. And I take this opportunity to thank Dr. Mittal once again. And I request Dr. Bagga, chairman of the SET facility, to present a small memento to Dr. Mittal on behalf of the SET facility and the All India Institute. Sir, इधर आए तो it will be seen. That's take it. Yeah. And I request Professor Rambuj, who is Professor of Cardiology, to present the certificate of appreciation. Dr. Ambuj is the faculty coordinator in charge of the SET facility. And thank you one and all for being here. Now I request all of you to join for refreshments in the pantry. Thank you.